So what I presented was a long-term follow-up of a pooled analysis of patients with mantle cell lymphoma treated with ibrutinib. So 3.5-year median follow-up of 370 patients across 3 trials. So the 2 early phase 2 studies and then the ibrutinib arm of the randomized study done in Europe. So what do we see? Well, consistent with previous findings, the earlier you use the drug, the better the outcome. And I think when we did the pooled analysis with this longer follow-up, that really became quite dramatic. So we know the PFS for ibrutinib is around 13, 14 months. That's true. If you look at patients who've only had 1 prior line of therapy, it's right out at over 33 months. So a massive benefit with respect to progression-free survival. The other thing that was obvious was not only do you get a better progression-free survival if you use the drug early, you get a better response rate. And that's relevant when you're looking at response between BTK trials. So if you've had 1 prior line of therapy, response rates approaching 80% and the CR rates approaching 40%. So much improved response rate, much improved progression-free survival. The other thing we saw, of course, with durable follow-up is we could say something about duration of response. And the better the quality of the response, the more durable the response. If you get a CR, the duration of response is around 4.5 years, which is extraordinary for a single agent. The other thing we were able to look at was toxicity. So for the first time we looked at toxicity relevant to prior lines of therapy. The earlier you use the drug, the less side effects you get, specifically from a hematological perspective, which I guess makes sense because if you treat people with a couple of lines of chemotherapy, their bone marrows are less likely to tolerate whatever you give next. So hematological toxicity, better if you use the drug later. Atrial fibrillation is the thing that people worry about. You tend to see that early. And of course with the ibrutinib studies, when we first started, we knew nothing about any cardiovascular signal. So patients who were likely or already had existing arrhythmias were on the study. So we could say something about those patients. There were over 50 of them. And I guess the take-home message is if you are at risk of getting atrial fibrillation and you go on ibrutinib, 70% of people don't get fibrillation. So you don't definitely get it if you go on one of these drugs. And the other thing was all the patients that got atrial fibrillation, grade 3, 4, on ibrutinib, remained on ibrutinib. So you didn't have to stop it. So what the trial did was give us some impressive long-term data. We are now confident about durability of response, particularly if you get a good response. And progression-free survival is miles longer if you use a drug earlier rather than late.